The second speaker for today's session will be Dr. Nitin Kapoor, Professor and Head, Unit 1, Department of Endocrinology, Diabetes and Metabolism, CMC Vellore. Dr. Nitin completed his DM and his postdoctoral fellowship in endocrinology at CMC Vellore. He then completed his PhD research on clinical and genetic indicators of obesity from the University of Melbourne, Australia. He has been cited as among the top 2% of most influential researchers across the world by Stanford University, USA in October 2023. He has also been conferred with several awards, including the prestigious A.R. Seth Gold Medal by the Endocrine Society of India in 2020, the Young Investigator Award by the Sri Lankan Endocrine Society in 2019, Melbourne Research Scholarship from the year 2016 to 2020, the Tamil Nadu Dr. MGR University Gold Medal in Endocrinology in 2015, A.B. Gandhi Award for Excellence in Endocrine Research in 2014, the IJEM Award for Excellence in Endocrine Writing in the year 2014, and others. He has spearheaded the write-up and is the editor of the current and the previous 2 editions of the book, A Practical Guide to Diabetes Mellitus. He is also the section editor of the obesity section of Endotext, the PubMed indexed endocrine textbook. He has more than 300 PubMed indexed peer-reviewed publications in the national and international journals, and his key area of interest is in the field of obesity and metabolic syndrome, pituitary disorders, and metabolic bone disorders. It's my pleasure to invite Dr. Nitin Kapoor, as he would be presenting on the 3 C's in understanding obesity, cognizance, causes, consequences, by shedding light on one of the most pressing health challenges of our time, obesity, and on understanding its layers, which is a key to addressing on it. Dr. Nitin, over to you.
Thank you so much for that very kind introduction. In the next couple of minutes, I'll build up on what Professor Samuel just taught us in terms of the problems related to lifestyle and how we can handle that with good lifestyle management. So I think we are going to talk about obesity, the 3 C's, but I'll focus on food because Food Safety Week is where we are right now. And the focus is on stopping junk food and how we can really ensure that this can impact our metabolic health. So I thought I'll start with some facts. And there is an organization internationally called the International Diabetes Federation. This meets once in 2 to 3 years. And one of the main things that happens when they meet is they bring up a book called the IDF Atlas, which is said to be one of the most awaited statistics book, which provides the most recent evidence and data with respect to the prevalence of diabetes, not only globally, but also country-wise, and gives very accurate projections for future. So the most recent IDF meeting was a couple of weeks ago in Bangkok, and they came up with this atlas, and what it showed was the statistics of diabetes globally, but I'll focus on India. And what they really showed was that we, at this point in time, have about 89 million people with diabetes in our country. And when we talk of its projection in the future, this is in 2050, right? So that's about 25 years later, we see it is becoming 156 million. So that's a very big jump. But just to compare how other countries are doing with respect to the diabetes prevalence, and we see India is the only country which has almost doubled, an increase of almost 70 million people with diabetes in a short span. You see even China, which is more populated than India, increases only 20 million people with diabetes. The United States, which is also fairly big, but 38 million, only becoming 43 million, only 5 million increase. So you see there's a very big problem that we are looking at in terms of diabetes and other metabolic disorders. And this is likely to increase rapidly in the coming future. And this is the most recent data that we can look at. When you talk of what are the causes of diabetes in anybody, and we see there are several things that we cannot change, but one important factor that we can focus on, which is possibly a reversible risk factor for diabetes, is obesity. And therefore, if we were to talk of how we can handle obesity or why diabetes and obesity go hand in hand, a lot of these points Professor Samuel Hansdorff had covered in his lecture, but if you look at, yes, definitely exercise and energy balance is something important. Our nutritional composition is important. We heard about fat, carbohydrate, and protein. Some things about genetics that we cannot change, or how our maternal health especially has been during early phases of pregnancy. Very important to have adequate amount of sleep, which is an important risk factor. Certain medications can increase both weight and glucose values. Birth weight, another important risk factor. So low birth weight would be a risk factor for developing diabetes and obesity in future, and environmental factors like pollution as well. But when we talk of facts of obesity, at this point, this is data from the NFHS 4, we find that about 35 to 40% of the Indian population is going to be overweight and obese. This was NFHS 4. This is slightly old data. But when you look at more specific data from Tamil Nadu, what we've learned is that the prevalence of obesity is increasing, but more so in men as well. All along, we've been talking of this problem of obesity in women, but you see that, 75% increment in men as well. But a long story short, this says that we are about 30 people in this room, or maybe 50 and another 50 online. So out of these 100 people, how many of us will have obesity in our lifetime? Half of us. How many of us will develop diabetes? Out of 100, how many will have diabetes? 1 in 5, maybe, or 1 in 6, so 15 to 20%. So that's the problem statement that we're looking even amongst us as healthcare professionals. This was NFHS 4 data. When you looked at NFHS 5, whatever was in late 30s has become early 40s. The problem is just increasing. It is increasing across age groups, be it children. This is again another study in Vellore looking at school children between the grades of 9 to 12. 30% of them have obesity, not only overweight, obesity. Even among young adults, this is data from the Vellore birth cohort. You see over a period of 10 years, prevalence of obesity in women from 30 has jumped to 70. That rapid an increase. And elderly are not spared as well. We are talking about field workers. This is a study that we've done in, working women from rural Vellore. Most of them are farm workers, and there also the prevalence of obesity is huge. And therefore, we have good guidelines in India. We have very good lifestyle medicine unit, which does a lot of work in endocrine. We run an obesity clinic or a bariatric clinic for obesity management. We have strict protocols that we follow. But with that introduction, I think we'll start with the first 3 C's. What all of us as healthcare professionals, as people working in hospitals, studying in hospital, should know of obesity. And the first C is knowing about how we find out if somebody has obesity or not. And I'm sure all of us know, how do we know that? Or how do we find out whether we have obesity or not? BMI. All right. So there's several obesity indicators. What you rightly said is we have BMI. BMI is easily calculated as kilogram per height square, height when mentioned in meters. And I think all of us are very well versed with the intranet that we have. And even if you don't want to do any kind of maths, we can just directly go here. All of us have access. We use our leave platform. Some of us who draw salaries go to this. So we have these calculators here. In the calculators, we click, we have a medical calculator. And all of us can do that sometime before we do something else on the internet. Once you click on the medical calculator, there is a place where you can enter your BMI. And once you enter that, this is what you get. You can enter your height and weight, and you can all calculate your BMI. Right? So this is something that we all can do. We don't need to go anywhere. We don't need to do any maths, but just need to know our height and weight. And we enter it on our internet, and we get to know not only the BMI, but we also come to know what is the desirable kind of weight for us, our given height and weight. We know our normal height, weight based BMI cutoffs are lower than the West. And normal BMI for all of us in India would be anything which is less than 22.9 kilograms per meter square. Anything between 23 and 24.9 would be overweight, and anything more than 25 would be defined as obesity. This is one way of assessing obesity, but if you want to do something simpler than that, what else can I do? If I don't want to do any calculation, forget intranet. I just want to sit and quickly in my mind know whether I have obesity or not. Something called as a Broca's index, very simple, 100 minus, your height minus 100, and then you will get what your ideal weight should be, right? So it's very simple, maybe another 5 added for women, but height in centimeters minus 100. You know, if your height is 164, your weight should be 64 kgs. So that's simple, but sometimes when you go to the doctor and you try and find out how much obesity they could do, sometimes, waist-related parameters, which are more relevant in our population. Sometimes at high end, we could do body composition analysis. But the point that I really wanted to drive today is that obesity is just not only numbers. We keep looking at BMI of 25, 26. Our patient comes back for follow-up. We say, okay, you've lost so much weight. But obesity is not only about numbers. Today, obesity is moving away from just redefining obesity to more phenotypic characterization. And what I would say is, like in cancer, we do staging systems. And believe me, obesity is no less a grave problem like, unlike cancer. But this is how a staging system of obesity can be developed, which is kind of recognized from an Indian perspective also, where you may have somebody who has obesity, which may be only, say, BMI of 29. But that patient comes to the hospital on a wheelchair because that patient has severe osteoarthritis of the knee, has florid diabetes, hypertension. So even BMI of 29, which is obesity, but then if they have so many problems related to obesity, they directly move on to stage 3. I may have another patient who's got a BMI of 35, but may not have so many problems related to obesity. Comes and says, doctor, I'm quite fine. And that could be just maybe on biochemical evaluation as mildly elevated glucose values, which is in pre-diabetic range. So that becomes stage 1. So you see, numbers are always not very important. This was very nicely proven in this study that was done using the US NANES database, where if you look at BMI, it doesn't predict mortality very well. This is follow-up for 15 years. And we see that if you are able to stage the patient, look at the patient's obesity status in a more holistic way, looking at all the comorbidities, we'll be able to better predict how much severe the obesity is and how they need to be classified. This is again data from our center. We find that in the obesity clinic that we run, we find significant number of people who've got obesity stage 3 and 4, and the guidelines today tell us how to manage this based on these staging systems. So the first point that I wanted to cover was assessment of obesity. All of us, in the hospital should have access to intranet and should be able to calculate our own BMI. And if you don't want to do that, another simple message that I leave you with is just ensure that you remember the Broca's index. Your height in centimeters minus 100 will give you your ideal weight, but just don't stick on to numbers. Look at weight as a bigger problem. And as we have multiple problems associated with obesity, we'll talk about it when we talk about the third point. Look at that as well in a patient with obesity and then understand how severe the obesity is for a given patient. Let's move on to the second part, and that's something which is most related to this Food Safety Week when we talk of causes of obesity. Now, today, we understand obesity is just not by choice of an individual. Often it could be related to some neurochemical changes within the brain, which could be either genetic, which could be either environmental, behavioral, a lot of causes that could happen. But obesity per se is recognized as a chronic disease. All these years, there has been so much stigma associated with obesity. Okay, this patient would be just eating more and walking less. Believe me, some of the patients who are severely obese are very, very cautious of eating food. And there are others who might be eating all the junk and still may not be having a lot of weight. So we need to understand that obesity is a medical disease. And all of us who are in the hospital setup, we may be working in the hospital, maybe ourselves, healthcare professionals, need to understand that there has to be very less stigma associated with obesity. We should use the right kind of terms, using wrong terms like heaviness, large size is stigmatizing. Recognize obesity like a chronic disease where you respect the patient like the patient has diabetes. You don't stigmatize so much when they have a disease which is more biochemical. But because this is so physically apparent, very important to look at these patients like they have a chronic disease and not giving any stigma. This is a study we did here in Vellore looking at how stigma is not only associated with obesity, but how stigma can also lead on to obesity. People who are stigmatized tend to develop eating habits which are worse, and then it becomes a vicious cycle. So this is something that is really important. Choosing your right words when you're talking to these patients, it's very, very important to empathize. And I think that's another important message that I'd like to leave you with. But when we are talking of, trying to understand why somebody develops obesity, I could divide the causes broadly into three aspects. Either they could have slow metabolism, or it could be a problem with respect to their food intake, or thirdly, it could also be because of reduced physical activity. I'll focus more on the food aspect because that's what the focus of this particular week is. But in general, when I talk to my patients who come to me for obesity treatment, I basically try and run through their 24-hour recall as to what they do in their entire day. And that helps me understand what is the predominant problem for that person. Believe me, all patients with obesity are not having the same kind of story. Somebody may have stress eating, somebody may have problems with related to limited exercise, somebody may be on medicines which are causing weight and they're not really eating well. So it's very important for us to know why a patient may have obesity, and food being a really important aspect. Professor Samuel just mentioned about the different types of diets that are available. A lot of family and friends could tell us as to, somebody has done intermittent fasting for so many days and they've lost so much weight, while others, somebody's following keto diet and they've lost so many weight. So if you ask me, which diet is the best for weight loss, the answer is no diet is best for the weight loss. The best diet for weight loss is the one that the patient can sustain for a long period of time, a diet that the patient can follow for a very long period of time. I may have patients who've done intermittent fasting, lost 15 kgs, very good. They stop it after 2 years and the weight is back, and often back with a vengeance. So they shot up even where they started with. So the best diet that we talk about is, kind of a patient-centric diet, a diet that the patient can follow long-term. We try and understand what the social customs of the patient are, and then we try and change the proportions first of what the patient is already eating in the house. Whatever the patient is already eating, it's easier to cook one thing more and the other thing less, rather than, get an absolutely new diet, which the patient may follow for sometimes, but not long-term. And all of this requires long-term follow-up. Very recently, we've been doing a lot of studies with reproductive medicine unit, trying to understand how this person-centered diet works for infertility, and it works really wonderful. We've done a pilot and we're doing a very big grant with ICMR on this. So person-centered diet is the right answer. There is no intermittent fasting, no keto diet. If the patient can do it long-term, that's fine. But if it's just a short-term solution, that's not something that is helpful. Another important aspect, especially when you're talking of Food Safety Week, and what we should convey to people is, again, match our carbohydrate to protein ratio. This is something that was highlighted in the last lecture as well. So eating a lot of carbohydrates, this is the famous START study, which showed that whether we eat a North Indian, South Indian, West or East Indian diet, all of our carbohydrate content in all these diets is about 66%, which is quite high. We need to reduce our carbohydrate intake. And when we compare this to the Western population, it is definitely very high. Either we talk of rural or urban India. So one important message when we talk of food safety or in terms of food junk that has to be reduced is to improve the protein intake in our diet. So if you meet somebody who's seeking help for obesity, a simple advice would be, okay, if you are having dal and rice for lunch, reduce your rice to half, multiply your dal 4 times, and that's something that very simply can help them attain more satiety. When you have more protein, you burn more calories, and therefore you lose more weight. This is a very big guideline, 25 pages on managing diabetes and obesity in our part of the world. There are a lot of points that I've written. But if there's one line that I really highlight out of these 25 pages, that would be to ensure good protein intake. Obviously, eating on time, no skipping of meals. As was mentioned, sometimes, eating healthy in different intervals, reducing the oil intake, and at the same time, don't disrupt the quality of life of the patient by giving them a very exotic diet that the patient will always be so concerned about that diet that they are not able to concentrate on other things in life. This is another study from our center, from the obesity clinic, where we see that the quantum of protein intake, despite these patients having BMI of 35 plus, and they are already eating a lot of calories, but still they don't eat the amount of protein that they should. So protein intake is important. I think fiber is something which is also highlighted. Having good amount of fruits and vegetables is something very important. Our diets are still very deficient in fiber. Most of the junk food is very deficient in fiber. Most of the processed food is very deficient. So again, when we talk of food safety, I think reducing junk food, we have to remember fiber intake. Another new concept which is coming up of late, we've always been talking about obesity in terms of carbohydrate, protein, fat content, but more recent data tells us that micronutrients are also important. Iron, B12, folate. So again, emphasizing eating the right amount of fruits and vegetables is also very important, because not only the macronutrients are covered, the micronutrients are also very important for obesity management. Again, this is another longitudinal study we've done, and you again see how the snack fruit pattern is definitely more healthy in preventing diabetes when we follow them on a long term. So again, the same message there. We're talking of causes of obesity. We also see sometimes very young children with very severe obesity in our practice, and sometimes, many times, it is still, because of the environmental influence, but sometimes it could be genetic as well, and that requires a separate treatment. With this, moving on to the third and the last aspect, talking about consequences of obesity and how this is really important. I think in this hospital, no matter where we work, whichever department we work, we see there are a lot of problems with obesity. So it's not that people with obesity have more than 270 problems that have been written. What is the important message here is that no matter whichever department specialty we work, if you are working in the respiratory department, patients with obesity will come there with obstructive sleep apnea. If you're working in the liver department, they'll come there with fatty liver. In the orthopedic department, with knee pain. So no matter where we work, the obesity-related comorbidity of that department will present to us. So all of us need to be aware about how to handle patients with obesity and know about it in the right way so that we can guide our patients correctly. There's several complications. This is the 4M framework, which easily divides as to how we have to understand the complications of obesity. I think all of us are usually very well aware about the metabolic problems. Whenever we say obesity, people will say, okay, we should talk about diabetes to them, hypertension, cholesterol issues. But what is also important is obesity is associated with psychological problems, with mechanical problems that are often not very well, addressed. So that's also important. Again, data from our clinic shows that 30% of people with severe obesity benefit from undergoing a good psychological evaluation. Of all these problems, I thought just one complication of obesity I would highlight in today's lecture. And the reason is we at CMC have just recently started a fatty liver clinic, wherein we, with Department of Hepatology, Endocrinology, Dietary, are all coming together to manage this very neglected disease, which is fatty liver. This is something that has been there for a long time. Many patients talk about it. It was mentioned in the previous lecture also, but I think the importance and the management strategies for fatty liver are often not very discussed. This is common. Again, when we looked at data from our clinic, we found that 75%, 3 out of 4 women who walked into the clinic had fatty liver. And the reason why it is really important is that it is associated with cardiovascular disease. So you see that the risk of developing cardiovascular disease with type 2 diabetes is only 0.5 to 2-fold, but with fatty liver disease, just 2 times higher. And many times people are aware they have fatty liver, but it's not addressed. And this is something I think in this Food Safety Week, I'd like to highlight. So with this, I'll stop. We just talked about the 3 C's about Cognizance of obesity, how we assess obesity, simple ways, assessing BMI. We can do it on the internet, Broca's index, but also remember that obesity is just not only about numbers. We try and address obesity as stages based on comorbidities that are associated. Assessing causes of obesity, diet, exercise, important, but remember, this is a chronic disease. It is often not by the choice of the patient. Complications of obesity, no matter where we work in CMC, we will get to handle patients with obesity, and we should do it in the least stigmatizing way, the way we should do it in the right, medical way.
Thank you once again, sir, for a very informative session, which enabled us to gain a good knowledge on it.
As we conclude for today's session, we extend our heartfelt thanks to each of our distinguished speakers, the organizing team, and to all the participants. Let's take these insights back into our homes, our communities, and our cafeterias and remind ourselves daily. Say no to junk food, yes to healthy choices, because when we eat right, we live right. Let's continue to learn, share, and transform together. Thank you.